honorary hemato-oncologist at Wadia Hospital, Mumbai. He is also pediatric head at PD Indira Hospital, and we actually know him as a vaccinologist. He has a immense, beautiful ability to explain the small points regarding the vaccinations, and I'm hearing him since last almost 20 years, and I'm clearing my myself. There are thousands of pediatricians all over India who are getting their doubts cleared by listening to him. At least since last 20 years, I am listening to him. Really thankful. Thank you so much, Nitin Shah sir, for joining us. And as we all know, as a IAP Raigad, we set a benchmark that under the able guidance of Dr. Wankhede sir, who through his contacts get us such a wonderful speakers, and all of our CMEs go houseful. Last CME of Dr. Subramanian was houseful. Before that, there are many CMEs. Dr. Khubchandani's CMEs of rheumatology, it was also houseful. So today also we are having a houseful CME. And I request our dear President Dr. Pramod Wankhede to give his presidential address.
Thank you, Vikas. Thank you very much. Today's respected expert, Dr. Nitin Shah sir, past President, Central IAP, Dr. Vijay Yewle sir, past President, Central IAP in 2014, sir was in 2006. Our MAHA-IAP President, Dr. Hemant Gangulia sir, my co, Dr. Vikas More, Dr. Dhananjay. I'm seeing some dignitaries on the board, of the board. I welcome you all and good evening to all. Dear friends, whenever we find some crisis, whenever we come in crisis, or even our state comes in crisis, we approach to these giants of in pediatrics, Dr. Nitin Shah sir, Dr. Yewle sir. Government also included them in task force to tackle the situation. In present scenario, when there is an outbreak in Mesles in Mumbai and suburb, in anticipating that may happen in our district also, in Raigad district, because it is in close vicinity of Mumbai and Navi Mumbai. And if this condition arises, we should be able to tackle this situation. That's why to update our knowledge, to get more information, we have got these astute speakers with us. Dear friends, we have got Dr. Arun Katkar, SMO, WHO, and Dr. Shinde, ADHO, Alibag. This duo will guide us government policies, government guidelines, protocols about the reporting and testing, etc. So without wasting much time, much time, I also welcome Dr. Vinayak Patil, Vice President, Maharashtra IAP. So without wasting time, I just request both experts to proceed further, and I hand over to Dr. Vikas More. Thank you very much.
I think before starting the session, I request our dear President Dr. Hemant Gangulia sir to give his thoughts in briefly.
Thank you, Dr. Vikas. It's a pleasure to attend this webinar organized by my home branch IAP Raigad as well as my president Dr. Hemant Wankhede sir, and we are already having a stalwart speakers who we have seen so many years learning from the Dr. Nitin Shah, Dr. Vijay sir. So we will have a good session on this, and probably this will clarify all the doubts whatever we have in the mind, and which will also be helpful in telling the parents when they ask the queries and questions to us, so we can solve that questions also. Wish each one and everyone a happy learning, and it will really clarify our doubts. Thank you very much.
So friends, thank you so much sir for your valuable words. Friends, we are today gathered for clearing out our doubts regarding the recent measles outbreak. It was really surprise to us why it happened, especially And was it happened really recently, or was it happening since last 1 year? That we need to know. Second thing, the structure of today's hearing is that we are having some questions with us. Myself, Dr. Dhananjay Rajput, and Dr. Wankhede sir will be asking questions to Dr. Nitin Shah sir, Dr. Yewle sir, Dr. Katkar sir, and in between Dr. Shinde sir, according to the need. And whoever want to ask his questions, please post your questions in the chat box. If the questions are in the theme, we will take the questions during the CME, and if it is slightly different question, we will take at the end. So, friends, we know like in today.
Because
Yes, yes, sir.
just I welcome Dr. Dabadkar sir, who is I'm seeing him on the board. Sir, welcome, please. Because carry on, please.
Yeah. So, welcome, Darwar sir. Thank you so much for joining.
Dr. Vikas Mori, sir, just a minute. On behalf of IAP, we have attended government task force meeting also, and one of the meeting, Dr. Nitin Shah sir was also there. So there is some discussion went on that. Dr. Arun Katkar was also there. So whatever the questions will be asked, probably that should be in consideration with that whatever the meeting happened. Of course, it was a different meeting because of the central government has put 2 points on the consideration to control this outbreak. So Dr. Nitin Shah and Dr. Vijay Yewle sir respond to the questions in respect to the whatever the government wants to do. Okay, thank you, sir.
Sure.
So we know since last almost a month, there are so many cases of especially measles coming attending to our OP. And more than that, the people are asking us questions that, sir, मेरे बच्चों को ये वैक्सीन देना है. Even 1 month old child or 2 month old child, they want to get the child vaccinated for measles, and there is a chaotic situation in the society regarding especially measles. It was never before like that. So, and there were no clear-cut guidelines, but happily now there is a task force is set up, and the guidelines are now coming, and we are having the faculty with us, which will definitely help us to take a right decision. So I will ask this question to Shah sir, that sir, what might be the potential reason of this recent outbreak? Like, was it like the COVID era, or was it the decreased surveillance from our side? So what might be the exact reason for this recent outbreak?
So thank you, Dhananjay. Thank you, IAP Raigad, for inviting us to be present here for this very important meeting on measles outbreak. And I think I would like to remind people that what happens in Mumbai becomes news. But it's not that Mumbai was the first city or the Maharashtra was the first state to have this measles outbreak. In fact, measles outbreak has happened in several other states of India, maybe even before Maharashtra, like Haryana, Jharkhand, Orissa, Bihar, Gujarat, etc. And not only India, but there are other parts of the world which also have been having measles outbreaks since last several months. So just to give an example, 22 countries in the world have experienced major and disruptive outbreaks of measles. And you'd be surprised that by 2021, that's almost before COVID, 82 countries in the world had eliminated measles and 81 had eliminated rubella. However, since the COVID outbreak and subsequently 10 of these countries, which were actually measles eliminated, these countries have got re-emergence of transmission of measles. So it's a global phenomenon and not for India specific alone. Now coming to our own problem and that the outbreak that has started in Mumbai and around, we can see several reasons why it has happened. One of the most important is that during COVID time, as we know, we have 5 lakh children born in India every week. So if suppose you take 3 or 4 months of lockdown period and another 3-4 months of lockdown-like situation, especially when the parents were dispersed and they went to their villages and some of them didn't come back for months together, we are talking about almost 20 lakh babies born every month, and 6 to 8 months of lockdown during COVID. We are talking about 1.2, 1.3 crore babies who were not in the best areas to take their routine vaccination. So the routine immunization definitely took a hit, and that you can see very clearly has still not picked up because as Dr. Gangulia was saying in the Maharashtra Task Force meeting, which was held just few days before, the data was presented on the MR1 and MR2 coverage for Maharashtra and different districts of Maharashtra. And it was surprising to see that for the 9 months that have started, that are ending now in December, because they start from April to the next March. If you take 9 months, like in average of Mumbai was around 45 to 52%. And if you add another 3 months in the next 3 months, it may reach around 65%, which is far below 80 or 85%, which was the national average before COVID started. So break in the routine immunization, especially for the marginalized people, people staying in areas where high density and people staying in slum-like situation, was enough reason to have a cohort of babies born since the last MR campaign who have not received their MR1, MR2 in time. And measles virus, as you know, was always endemic. It spread like wildfire in these areas. So this is essentially the reason why we are having these outbreaks of measles in the country, in the world, and especially in the city of Mumbai. If you come to Mumbai, then if you see the hotspots are the Govandi area, the Entofil area, and some parts of Dharavi. And now more than, almost 16 out of 24 municipal wards have had at least one or two outbreaks. And out of 210 health posts, more than 55 have recorded outbreaks. So it has spread to the other parts, obviously, because of migration of people. So we need to strengthen routine immunization and to catch the children who have not received their MR1, MR2 in time, and also take measures to control the outbreak by outbreak response immunization. That's the way to go forward. But if you just do a knee-jerk by giving immunization now and then again relaxing, and you allow another cohort in the next few years to build up with poor routine immunization coverage, we are going to have this outbreak every 3 to 4 years, as used to happen before effective immunization. So it is not just COVID alone. COVID is a major factor, but there are other factors. Of course, vaccine hesitancy, high density, poor hygiene, indoor pollution, highly congested areas, reluctance by the people, mother education being not that great in some areas. All these have added together to lead to this today's measles outbreak.
Thank you, sir. You are very rightly said that we are getting these hotspots in the Mumbai, like Govandi and Topville. Today, only in the evening, OPD, I saw a patient from Govandi with a post-measles pneumonia in my OPD just 1 hour back. So the patients are spreading throughout Mumbai from this hotspot, and it may definitely cause a havoc if it is not properly controlled. The question to Yewle sir is that, sir, what is can you more elaborate regarding this underprivileged versus high-rise building cases?
Basically, if you allow me to speak for about 2 to 3 minutes, let us look at what happened over a period of time. Nitin would agree, when we were residents, we used to see loads of cases of measles. And I would say only the plus point of this bad outbreak is young pediatricians who did not have opportunity to see measles are getting to see cases of measles. Well, that's not the, let's not call it a plus side, but that's a, maybe a positive out of this sad outbreaks which are happening all over the country. Now, if you look at the measles, the World Health Assembly had declared a mission to, eliminate measles and control rubella, which was to be achieved by 2020. Now, measles is a very highly contagious disease, but fortunately, a very effective vaccine is available. Now, this vaccine, when given at the age of 9 months, leads to seroconversion in 85% of the recipients. So, in India, before we took up the campaign immunization with the MR vaccine or measles vaccine, there were, India was not the country which was using 2-dose measles and did not belong to the league of countries which had eliminated measles. So it was decided to undertake this mass vaccination, and we embarked on that MR campaign. And by 2018, we had excellent coverage, and we are almost on the road to eliminating measles. We had definitely achieved good control. Unfortunately, India was one of the countries which was not using second dose in public health sector. Now, having said that, just calculate that it's a highly contagious disease with R0 of almost 15. So to have good control, we need to have very high level of coverage, community immunity or population immunity of 85%. 85% seroconversion single dose, and coverage of 85% would usually give rise to a good amount of coverage and population immunity to halt transmission. And we achieved that with the help of and the moment the vaccination faltered, the children who were not immunized, the numbers started growing. And apart from the COVID, which was one of the reasons where outreach vaccination suffered for a few months or a few weeks, I would say. The routine immunization suffered. And then the vaccinees, the parents were also very reluctant to come out. So both put together led to dip in routine immunization, number one. Number two, the country is increasingly being plagued by the phenomena of vaccine hesitancy, which is known for ages, but somehow it is increasing. And with due respect to caste creed communities, there are certain communities and certain pockets where there's a lot of misconception, and they just don't come out to, they just are not willing to vaccinate their children. So all this put together led to outbreaks. Vikas, you said we were surprised, but honestly speaking, this was ought to have happened. I mean, the epidemiologists were contemplating, and if you remember during COVID time, so many webinars and these things were conducted, both CDC, WHO, and even in India, IAP also was on forefront in, appealing to all the pediatricians, common people, to ensure that the routine vaccination is back on track as soon as possible. Unfortunately, that did not happen. And with such high, R0, it was bound to occur, especially in crowded areas where underprivileged children stay and malnourished children stay. And as Nitin said, what occurs in Bombay catches the media. But the outbreak started appearing way back in 21. Haryana, Bihar, Jharkhand, Odisha. From there, a lot of outbreaks were already being reported. And what came in Mumbai, I would not say was really a surprise, but it was, in fact, Katkar is here. He would agree with me that in Navi area, Katkar we worked together on typhoid project, and he impressed upon us the importance of doing surveillance where the polio task force or polio force was then having control polio was asked to undertake surveillance for measles or fever with rash with that WHA's mission of elimination of measles by 2020. Despite this surveillance, somehow everything put together led to this unfortunate but not anticipated outbreak of measles. And with every passing day, cases are increasing, which was bound to happen. In the past, we used to see so many cases of measles. This is coming as a sort of a surprise because there was a lull in between of many decades. But and I'm sure with the government machinery, IAP backing the government machinery, and with an excellent public health, public-private partnership, we are bound to overcome this short-lived, so to say, disaster, and we'll come out of it.
Because I want to ask you.
Just to add, if you can
Yewle,
allow
sir.
me.
Yeah.
So Shah sir, you want to say something?
Yeah. No, I was wanting to say that the question that you asked, whether high-rise buildings are safe or no. So as on today in Mumbai, which is the epicenter of outbreak in the country and in the Maharashtra, there has not been a single case from any high-rise building, even if they are falling in the area where there is measles outbreak in a given municipal ward. So that's reassuring. Maybe because one, there is less chance of contamination and transmission, and number two, many of these children are highly immunized. And that brings to the spot on immunization. When you go measles containing vaccine at 9 months, your seroconversion is 80%. If your measles coverage for MR1 is around say 80-85%, if you multiply 80 by 80, you are having 60% of children who are having immunity at that time. 40% are either not taken or have not seroconverted with the first dose. When you give the second or the 16 months, one, it boosts the immunity in those who have already seroconverted, and two, it gives an opportunity for those who have missed their first dose. Now, when you give the second dose at 16 months, the 95% is a seroconversion. So you expect 95 out of these 40%, that's almost like 38% to get seroconverted with the second dose. So now you add 60 plus 38, it becomes almost like 95, 96. You need 95% plus children having measles antibody in an area to stop or to prevent transmission of measles virus happening ever again. Now, if for that you will need a consistent 85 to 90% coverage for MR1, and more important, another 85 to 90% coverage for MR2. But unfortunately, during COVID and even before COVID, it was not at the best. And during COVID, it became even lesser. And that's the reason why we are having a gap in the community immunity. Now, remember, people blame MR campaign failed as the cause of outbreak. I must reiterate here that MR campaign was an extremely successful campaign undertaken by public health in India. In fact, these figures say that out of 290 lakh children, that's 29 crore children who are eligible for 9 months to 15 years to receive that MR during campaign, we achieved 96% coverage. That itself was enough to eliminate measles. And that's what exactly happened. The measles disappeared almost. We had 1 or 2 cases in 2021, some 2 cases in 2020 like that. And suddenly now 500, 600 cases. That's because during the COVID, the routine immunization has altered, and the effect of MR campaign. After that, whosoever children are born in the last 2.5 years, and if they have not received MR1, MR2 in time, they are the ones who have been able, are the chain of transmission for the measles outbreak. And I again remind you, unless we improve our routine immunization to more than 90% for MR1 and MR2 consistently, we will not be able to eliminate measles. That's why if you see measles elimination 2023, which is a dream project by the government of India in India as such and in all parts of the India, will not succeed unless you have more than 95% coverage for MR1, MR2.
Because I forgot to, I did not address the question specifically that you raised. But
Yeah.
while it is unlikely to have outbreaks in high-rise population, there are cases which are coming from even high-rise buildings. Just to give an example, I have a child admitted to Apollo hospitals who is to stay in Sector 9 of Vashi. He is shifted to Seawoods. This child had fever for 3-4 days and then started developing measly rash. His dengue serology came positive, but then it looked like measles, congested eyes, and rash which started around and behind the ear and which gradually started spreading down. And his antibodies are positive for measles IgM. So such cases are bound to happen because, as Nitin said, unless you have 90-95% population immunity, it is unlikely to control measles altogether. But it is very unlikely to have outbreaks in high rise because most of the population is, I presume, they have received the vaccine, and most of them, at least in November, the MR campaign was 95% plus. The coverage was almost 99%.
Yeah, thank you, sir. So the discussions leading to the various thoughts. For example, Dr. Alok Gupta has mentioned the autism, which has really, it was a very controversial Lancet paper, which really caused huge damage to the vaccination throughout the world. And it really increased suspicion. I remember one of my Russian friend from Moscow, he haven't given a single vaccine to his child just because of reading this paper. And his child is now 10-year-old. So this is happening in Moscow. And we are talking in India.
So I must remind you here that the paper by Andrew Wakefield and his group on MMR and autism was officially withdrawn by the journal. There are very few incidents of journal withdrawing paper. One of them was Andrew Wakefield, and in fact, he was reprimanded in Britain for putting up this nonsense theory. Subsequently, every society, including the autism societies all over the world, have exonerated MMR or any vaccine as a cause of autism. Just because you give MMR at 12 to 15 months and autism is suspected at 18 to 24 months, it's a casual relation and not causal relation between the two. So suppose I go out and I get knocked down by a car, I say I drank water at my home, that's why I got knocked out. So it has nothing to do with my drinking water. Same way, there was nothing to do with the MMR vaccine. In fact, after world over MMR vaccination, the incidence of autism in general has gone up even in unvaccinated people. But that's because of increased awareness and not because of a specific vaccine. So no one should have fear of MMR leading to autism, or for that matter, any vaccine which is against a life-threatening illness in children, having any serious adverse effect, enough to negate use of that vaccine. So we must encourage all public health vaccination and other vaccination, even in private, to be encouraged liberally to our patients.
The
While
result
autism
also,
has been, while autism has been very often cited as one of the causes of hesitancy for MR or M or MMR vaccine, honestly speaking, that's not the only reason of hesitancy. Even in private sector, I don't know, Nitin, would you agree with me that not many people are hesitant because they are out of fear of autism? Even in
No,
private sector.
absolutely not. Absolutely. I think that was there 20 years back, but no more.
Absolutely. So there are several other reasons why people are hesitant with taking MMR.
So just to talk about the vaccine hesitancy, I mean, in today's paper, if you see the family which lost two children of measles from Govandi, and the mother was pregnant at that time, and
Yes,
now
yes.
she delivered a baby, and the baby was due for 6 weeks immunization. This time she accepted it, saying that, okay, I know these vaccines save life. So,
Yes, sir. This is the
if
news
an
in
example,
Times.
yeah, so if an example is set, and with the workers at the field workers from the ministry, from municipality, from WHO, all joining hand with the local doctors, religious leaders, etc., have now impressed upon enough to the community that no, these vaccines are for their children's life saving, and they should take, and they are coming forward to take the vaccine.
yeah, the reason behind taking this point was because besides pediatricians, there are many government medical officers have joined this program today,
Right.
from Kharghar to Mahad Mangaon. So they should also know this fact that this paper has been taken out and it is no more in the Lancet.
Yeah.
So,
In fact,
sir,
I would really wonder whether in a public health setting, anyone would know autism and MMR and those things. These are all for people who are highly educated and misguided, who talk about this in our private practice. I really don't know whether any municipal hospital or a municipal health post, anyone even raises doubt about MMR leading to autism. They may in general feel vaccines are not required. That's a different thing, but not for a specific reason.
very true, very true. So
Because-
regarding the deaths, like, can you elaborate there are 10 to 12 deaths happened during this breakout. So what is the breakup of these deaths?
So a little more than that, I would say. There are around there are 2 deaths from Thane, 1 from Vasai, 2 from Bhiwandi, and rest all are from Bombay. So around 18 deaths have happened so far, except one child who received 1 MR vaccine. That to not 2, none of them were vaccinated. So that should reassure you that if you are vaccinated, 1, you will not develop measles. 2, if you develop, it will not be severe enough to leading hospitalization. And 3, even if it is moderate to severe, it will not lead to death.
So what is the youngest child affected?
Youngest child affected the measles-like illness. I mean, that other day when we did the Mumbai program, Dr. Radha Gildiar from Sion Hospital and Dr. Belavara from JJ Hospital, who are the respective HODs and the head of the department and head of units, they said that they have children with 3 and 4 months old also who are admitted with fever with rash. Of course, they were not proven because their antibodies test was sent, but the results were awaited. But clinically, they said they look like measles. So in the world, we have a small child as small as 5 and 6 months having detected measles, definitely. And even deaths have happened in such small children. I think the youngest death probably was 7 months, if I'm not mistaken.
It is extremely rare to have measles below the age of 6 months. Extremely rare.
Yeah. So, Yewle sir, can you elaborate regarding the immunization and nutrition status of these children who got really seriously sick?
As Nitin said, if you look at the breakup, children who got sick and who got measles, majority of them, more than 70-80%, had not received even a single dose of measles vaccine. And it is known that a child who is seroconverted gets 1 dose of measles vaccine, gets attenuated form of disease. And less than 10% of children had received, at least 1 dose. So most of them were unvaccinated. So measles is a good vaccine. So 85% seroconversion at the age of 9 months is a reasonably good vaccine.
Sir, is it the same
around
strain or some mutant strain is there in outbreak?
No. The NIV at Hafkin has checked the virus strain. It is the virus strain which is there since last 2-3 years, the 368 strain. So there is no mutant strain, which is the reason for either as a vaccine or antibody escape mutant or something different virus to which we don't have enough antibody. That's not true at all. It's a virus which is existing for last more than 3 or 4 years. And just to add the vaccination, around I think 8 to 10% children had received 2 doses, but we did not know when they received the last dose. So that was still being worked up. So as you know, if you have not received the antibody start around 2 weeks after your last dose, and if you have taken vaccine very recently, it may not protect you completely.
But
As we
Nitin,
all,
I have a question here.
Yes.
Waning of immunity against measles. We never discussed about waning in the past.
Correct.
So, regardless of the time lapse since vaccination, why should it be a cause of concern now?
No, not that way. If you're taken the first dose itself now, it takes 2 weeks for you to be protected.
Yeah, that's a different thing. Yeah.
So if they have taken 1 dose, but if they've taken very recently, they may not be well protected, especially if they're malnourished. They may not mount good response. And as I said, if you take MR or a measles containing vaccine at 9 months, your seroconversion is 80%. So remaining 20% don't seroconvert. So they are as good as not taking any vaccine. So that's why they can fall prey.
No, but let's clarify this. For those who successfully seroconvert,
yes,
there is no waning of immunity and they are pretty well protected.
Yes. So as I said, the second dose is actually to improve immunization of the children who have not seroconverted with the first dose, which is around 20%, and give an opportunity to receive at least 1 MR when you give the second MR for those who have missed their first MR. So I hope I'm clear that suppose you take 100 children, you give them MR at 9 months, 80 will seroconvert, but all 100 don't take, only 80 take. So you have 20 who have not taken and 20 who have not seroconverted. You have 40 out of 100 which are not antibody positive. Those 40, when they go for at 16 months for the second dose, 95% of those 40 will now seroconvert. So you have now made 96% of the community having antibody, and that's enough to stop the transmission. If that doesn't happen because of your either poor MR1 coverage or poor MR2 coverage, then you have a trouble that you have enough children in the community which are likely to be part of chain of transmission, and should the wild virus enter, it will spread like fire.
Sir, is it time for one more round of MR campaign?
So we can discuss what is the outbreak immunization response immunization, and what is that extra dose versus 0 dose, which is the current state of affairs, which is as per the central government NTAGI discussion and recommendation, which is also followed by the government of Maharashtra and by the Mumbai Municipal Corporation. But just to give an extra MR to every child who is in Mumbai or in Maharashtra, I don't think that's a good idea, because that's not required as on today. What is required as on today is the 1 extra dose of MMR to children between 9 months to 5 years who are staying in areas or the health posts which are declared to have outbreak. All right. So not even the entire municipal ward, only that health post. And there is a registry of every health post having number of children who are below 5 years and number of children who are between 6 to 9 months in that health post. And those children only will be targeted with that extra dose. And in areas where there is outbreak of measles with more than 10% cases happening below 9 months of age, which means now you're talking about measles happening in 6 to 9 months, where you are not giving even the first MR because you're giving it 9 months. They are the ones which will be given that extra dose, which is now called as 0 dose, because that's not to be counted, and they will receive their first MR at 9 months and the second MR at 16 months as per the age, and keeping minimum 28 days gap between the extra dose of the 0 dose given now and the next routine immunization dose of MR if it's following, it will be given after 28 days. And in fact, just to improve, as I have been saying, that we have to improve routine immunization coverage if we want to prevent another mishap happening in the next few years. So while you do this outbreak response immunization and cover children with the extra dose in the area where there is measles outbreak so that you break the transmission, but you strengthen the routine immunization by catching children in the entire state of Maharashtra who have not taken their MR1 or MR2. And this exercise will start from 15 December. So from 15 December to 25th December, there will be a campaign made of giving MR1 to all the children who have missed their MR1, who are eligible because they are more than 9 months, irrespective whether they are in measles outbreak area or otherwise. Okay, and they will be given 1 more dose of MR after 1 month. So that will be from 15 January to 25th January. I think that's a very solid program. And I'm sure by March or April, we will probably not have to discuss measles outbreak anymore.
Wonderful.
Vikas and Nitin, Dr. Katkar is here.
Yes.
There is a bit of confusion amongst practitioners. I'll tell you why. See, today a 7-month-old child came to my clinic in November area, and he's due for his second dose of influenza vaccine at 7 months, day after tomorrow. Somebody visited his house and said that he's only 6 months and 20 days, 25 days. And the corporation worker told him that now the corporation has announced a 0 dose to all children. Outbreak is defined as 5 lakh cases, 2 cases, confirmed cases.
Correct.
So Dr. Katkar, you have to clarify, because there is a lot of confusion. And this parent was told that as a policy, every child is now being given MR, whether he is anyone who is above the age of 6 months, number one. Number two, they were also told that you will not be able to take any vaccine for 28 days after this dose. So Dr. Katkar, since you are here, can you clarify? I mean, there's a lot of confusion amongst practitioners, amongst public, and perhaps what is being, recommended by as a policy by the state health secretariat. Is there a confusion in conveying the messages to the health post workers? What is it?
Can someone allow Dr. Katkar to unmute, please?
Katkar sir, are you there?
Yes, sir. Good evening, sir, and thank you, Dr. Wankhede, sir, and IAP for inviting me. I think, as Dr. Yewle, sir, has said, I think there is some confusion in the field, right? Because guidelines are very much clear. Even we had state VCs on this particular topic, and they have clearly given the guidelines as per the decision taken by the task force committee. And Dr. Yewle, sir, is also member of that committee. So in that, it is clearly mentioned that 0 dose will be, as Dr. Shah sir has already told us, that 1 dose will be given to all the children between 6 months to 5 years in a confirmed outbreak health post area. And that is a 0 dose, okay, 6 to 9 months. So that will be given only in that area where we have the confirmed outbreak, right? And if we have cases in between 9 to 5 years, then we'll be giving 1 additional dose in the age group of 9 months to 5 years. So I think, sir, we have to find out and we have to clear the confusion. I think if we any health worker we have.
And if you look at the circular which is signed by Dr. Sadunke, it says that there will be 2 doses campaign carried out, one in the month of December, second in the month of January.
Yes,
and
sir.
distributed to all children.
Yes, sir.
That is
No,
the
no.
routine immunization
Yeah.
catch up. It's
This is-
nothing to do
yes,
with the
yes.
outbreak response.
Yes, sir. It is just to basically today we had a state VC on that also, sir, regarding this campaign, which we will be conducting from 15 to 25th of December, and in January again the same dates from 15 to 25th. And state has clearly given message that all the remaining children who are due but not vaccinated for first dose of MR or second dose of MR, those children should be identified and by doing the survey in throughout all the districts and corporations, irrespective of whether they have flagged outbreaks or confirmed outbreaks. So they will prepare a list of all due children. It is not an additional dose, right, throughout the state, but that will be these are the doses where those children who are not received. So these are the remaining doses of MR first and second dose. We'll prepare the list, and even they have taken a stock of whether availability of the MR vaccine at district level, and even a vitamin A, because they are going to give first dose of MR and along with the vitamin A, and again the second dose of MR with the vitamin A dose. So that is clear, sir. We are going to give vaccine to the remaining children, not to all the children those who already received. It is just a catch up. What is Dr. Shah sir has said just now? Yes, sir.
So I think let the audience be very clear on 3 things. Number 1, 0 dose is for 6 to 9 month children,
Yes.
only in areas with measles outbreak, and that too where more than 10% cases are below 9 months. Number 2, extra dose of MR to children who are between 9 months to 5 years in areas where there are measles outbreak, irrespective of their previous immunization. That is a this outbreak response so that you curtail the transmission. And number 3 is, as I have been saying before and again, that you have to strengthen your routine immunization. So to strengthen that, people who have missed their first dose and second dose of MR, they will be now enlisted in every health post or every municipal ward, and they will be given that dose. It's not an extra dose. It's the routine immunization dose which they have not taken, to be given in a campaign mode. So they do it very fast in a given time, like how we did polio. And that will be between 15 December to 25th December for the MR1 and 15 January to 25th January for MR2 along with vitamin A.
Sir,
So there is no panic for the pediatrician to give an extra dose of MMR to every child that comes to visit you. And I think we must not do this. Don't use this panic as a reason to give extra dose unnecessarily. Number 2, it leads to panic in the parents who have not taken, and we have to counsel them that number 1, is your child from the area where there is measles outbreak? Then you follow what the public health is going to do, and that time they will be given MR like how you are given MR during the MR campaign. That's the end of it. So 0 dose, extra dose, everything we should leave it to the public health instead of we interfering and leading to more confusion.
Sir, actually, we IAP means we are recommending 4 to 5 years of MMR.
Third dose, yes.
Does government with this outbreak, do we are recommending again that government should also give MMR at 4 to 5 years in routine immunization?
No, so they are giving, first of all, MR, not MMR, because mumps is
Yeah,
not
MR,
important from public health point of view as of today. But the MR, as the outbreak response is for children up to 5 years. So in that sense, it's an extra dose for them. Like suppose there's a 4-year-old child who's taken MR1 at 9 months, MR2 at 16 months. If he's from the area of government, he will also take 1 more MR.
No, I'm talking about routine immunization.
In routine immunization, though, it's only 2 doses.
MMR.
So that brings to an important point as to why in private we are giving third MMR.
Yeah.
Okay, so if the organizer allow me 2 minutes, I will clarify this so that there's no confusion.
Yes, sir, please.
So the government gives MR, right? As I said, rubella vaccination given at 9 months is almost 98% seroconversion. Another rubella given at 15 months leads to 100% seroconversion. That boy or girl is protected for life. Give measles vaccine at 9 months, there is 80% seroconversion. You give another measles at 16 months, that is 95% seroconversion. 2 together is almost 98% seroconversion. So you give MR1, MR2 at 16 and 18 months, then that sees you for lifelong immunity against measles and rubella. Now, when it comes to mumps, there are data available that mumps given at 9 months is only 70 to 72% seroconversion. And mumps given at 1 year and above needs minimum 2 doses to have 95 to 98% seroconversion. Still, it's not 100%. And over the time, even with 2 mumps containing vaccine beyond 1 year, the immunity wanes when you become adolescent. So if there is an outbreak of mumps, like is happening in Kerala, like is happening in USA, the third MMR is given to adolescents during an outbreak situation. So mumps is a different thing. We are giving MMR and not MR. So we have to necessarily give 2 mumps containing vaccine, which is MMR for us, beyond 1 year. So we give 1 MMR at 15 months and 1 MMR at 5 years. So that is different situation than giving only MR, which is enough to give at 9 months and 16 months. So I was clear as to why we are giving 3 doses and public health gives 2 doses, because we also give mumps component which the public health doesn't give.
Thank you so much.
Upper age limit for the catch-up vaccination is 5 years, but there is no plan of the public health to introduce another MR at 5 years of age.
Correct.
It is 9 months and 16 months only.
Yes.
There is one more question from Dr. Dr. Alok Gupta, sir, that why there are no outbreaks outside Mumbai or outside Maharashtra? Is it so?
So there are outbreaks in, I said, Orissa. There are outbreaks in Haryana. There are outbreaks in West Bengal. There are outbreaks in Gujarat, Ahmedabad. There are outbreaks in Maharashtra in 7 to 8 districts. So it's a matter of time when it will happen somewhere else. It all depends on whether you have a high density of population in slum-like area where children have not taken enough MR vaccine and the disease is endemic, it will catch like a wildfire. If you're in a state where there is like Himachal Pradesh, where there is so much less population, it is all distributed all around in the hills, then the chance of a cohort building up is not as much as happening, say, in slums of Govandi or slums of Dharavi. And you look at the hotspots of measles outbreak, they are exactly the hotspots where the MR and MR1, MR2 is lacking in general. These are the hotspots where there is slum-like area with reluctance to take vaccination. These are the hotspots which are also the hotspot for last cases of polio. So this is a problem of the community not accepting vaccination, routine immunization with that is as much as happening in the other parts of the country. And that's the reason why you see within Mumbai, high-rise building, good communities, lot of vaccination done, they are not suffering from measles outbreak. Even when, like say, I am in Sion area, a stone throw away from Dharavi, but still children of Sion, no one has recorded a single case of fever with rash of measles. And same way Mumra, same way Vasai, same way if you see other parts of the country where there are these ghettos of a community and the problem of density population reluctant to take the vaccine is the reason why you have such outbreaks.
Yes, so the one more important question by Dr.
So before I forget, there is an outbreak of 3,000 cases of measles, if I'm not mistaken, in the border of Orissa, West Bengal, and Jharkhand. Now that's huge. 3,000 confirmed cases we are talking about is almost 6 times bigger than what is there in Mumbai today, or almost 3 times more than what's there in Maharashtra. So we are not alone, the state. Only we are very agile. We do very quickly and we are very transparent. So we come in news.
Sir, just to add on that, sir. In Maharashtra, we started getting confirmed outbreaks since last 1 month or 1.5 months.
Correct.
But before that, if you see the data of whole country, since January till 10th of October, before we started getting outbreaks in Maharashtra, we had 160 confirmed measles outbreaks throughout the country. So we had a lot of confirmed outbreaks in the country, and now we have started getting in Maharashtra. Thank you, sir.
Including Dr. Katkari, Haryana, when it started in June.
Yes. Yes.
And in some areas of Haryana, there were more than 200, 300 cases from small areas. Like they are small districts. So it never came in paper because, as I said, my opening statement was what happens in Mumbai is a news, whether it is film, whether it is politics, or whether it is health.
Yes, sir.
So simply that our media is quite agile. So whatever happens in Mumbai becomes the news.
No, I'm happy because if that happens, then we take action in time and we don't allow it to go out of hand. So I'm happy about it. I don't worry about being news so far as that news helps me to become more alert and do the best for the community.
Very true. Very true. Sir, one more interesting question from Dr. Jitendra Gwane. That this outbreak has been seen above 5 years of children or even in the adults. So why the extra dose is only up to 5 years?
Dr. Katkar can throw the light on the age distribution. I don't think so. There has been an adult case among the whatever 1,000 cases which have been reported from Maharashtra, but I stand for correction. I had asked the SMO from Mumbai and she was very categorical saying that there are hardly any cases above 5 years of age. Dr. Katkar can throw more light.
Yes, sir. Even now, I have the data of Raigad. Whatever positive cases we have got. Now in Raigad, we have around 14 confirmed measles cases, and out of that, most of the cases are between 9 months to 5 years. Sir. Hardly one case I think is above 5 years. So more than 90% cases are above. Between 9 months to 5 years. Sir.
So we have seen measles cases in adolescent in the past, but these are rare and few and not as an outbreak. In the outbreak, it is still most of 98% children below the age of 5 years is what I would say.
So as Nitin said, though measles can occur beyond the age of 5 years, when a public health strategy is planned, the probability and the cost effectiveness is taken into consideration. For one rare adolescent, the program would not, start immunizing all the adolescent against measles.
I think this has answered to the question of Dr. Jitendra Gwane. If he is there, he can ask the question directly.
Would allow him to unmute.
No, sir. There are few cases who are around 6-7 years and they were never vaccinated. So this is a chance for them for rubella and other things also.
So that brings the question to Dr. Katkar. There is our routine immunization campaign mode or otherwise open to giving the missing MR to even children above 5 years? That's the question. Forget whether as an outbreak response, but as a routine immunization campaign or in future routine immunization. Suppose a 6-year-old child comes to public health post, has not taken any MR. Would you give him MR1, MR2 20 days apart?
Uh, as of now, the guideline is to vaccinate all the children between age group of 9 months to 5 years
5
only,
years,
sir. Yes,
correct.
not above 5 years. Yes.
But I think in our practice, we must give MMR vaccine to anyone who has not taken any MMR in the past, irrespective of the age. In fact, so many students who are going abroad to USA, most of the universities ask for either 2 MMR certification or anti-measles, anti-rubella, anti-mumps antibody. Many times the parents are not ready to do the 3 antibodies. So they take MMR with us if either they have not taken or the record is missing. There is no upper age limit for MMR vaccination. Absolutely not.
But I think with the mission of elimination of measles by 2023, I'll not be surprised if there is another round of MR campaign where it will be from 9 months to 15 years of age.
Yeah, that happens, that'll be good. But it's
Yeah.
not an easy task to do
I know,
one
I know,
campaign.
I know. But
Dr.
what I
Katkar will have
Yeah.
heart attack to hear that he has to plan for one more MR campaign. Even in Maharashtra, forget about the entire country. There was
Yeah.
such reluctance. And I remember school principals, so many celebrities, lot of us pediatrician, presidents of past presidents, we all put our own private videos, we circulated, and that still pushed the MR campaign to the success of around 90-95%. And in some areas, it was still around 80-85%. So it's not an easy task. So unless we are pushed to the wall, that will be something which will be drastic.
And
So what are the likely causes of outbreak other than vaccine failure, not taking vaccines? Other causes, maybe related with nutrition.
So if you are malnourished, if you are HIV positive, if you are immunocompromised, if you have vitamin A deficiency, I would even to say that even if you have vitamin D deficiency, it makes you more prone to develop any infectious disease, including measles, and especially severe measles. But besides vaccination, these are other very what do you call supporting evidence to say that it will help you immunize all immunity better or develop a better immune response. But that's not like, suppose just because you have vitamin deficiency, you will develop measles. It's not like that. But we must in our practice try to make good nutrition, including vitamin A and vitamin D. I am sorry to say, but private practitioners are very reluctant to give vitamin A to children. You know, vitamin A program is existing since the time we were students. First vitamin A with 9 months MR, then you give every 6 months till 5 years of age. So that child receives almost something like 9 or 10 vitamin A. And there is a Cochrane review which has been published in 2022, which clearly shows that there is definitely a survival benefit for those children who received vitamin A prophylaxis compared to those who have not. I'm also aware of a study from North India by Dr. Umesh Kapil. He was the PSM head of department at the All India Institute of Medical Science, where he did a study on giving vitamin A prophylaxis like this in well-built children, good nourished children, and he said it might be counterproductive. But I think one study doesn't make or break any recommendation. So we don't give and we don't encourage our good class patients to go to public health and take vitamin A. That's why I have been after the SMOs in Bombay saying that you please give us vitamin A bottles. And we see to that we will give to patients who come to us. And now, very fortunately, today only I received the first bottle, and I'm sure anyone who wants it can receive this vitamin A. Because you know, vitamin A Equazole injections are not available. Vitamin A syrups are not available. Abbott probably makes vitamin A tablets of 50,000 units, but that I'm not sure how much it's available. So we really have trouble if you have to prescribe vitamin A. So either you have to send them to public health or you keep a stock with you.
Sir, one brand is there, AVT drops. AVT drops.
Yeah, but how much is the strength?
It contains 1 ml 50,000 units. 1 ml contains 50,000.
Correct. So if that is available, then you can use those. Otherwise, easiest is you ask your municipal ward office. They'll be very happy to share a bottle with you.
So what is dose strategy?
So dose strategy for below 6 months, it is 50,000 units day 1, 50,000 units day 2. This is for children with fever with rash. Irrespective whether they are diagnosed to have measles, you don't wait till then. Then for children below 1 year, that means 6 months to 1 year, it will be 1 lakh unit on day 1, 1 lakh unit on day 2. And for above 1 year, it's 2 lakh unit on day 1, 2 lakh units on day 2. So I had one query from one of the Navi Mumbai members who said that he had a 6 weeks old child admitted with fever is rash. He said, shall I give vitamin A to them? I said, yeah, by public health, you give him 50,000 units, there's no harm at all. So what are the side effects? When you give vitamin A, you're worried about hypervitaminosis A, which leads to benign intracranial hypertension, as all of you know. So some of the children can have vomiting, and if they're small, their anterior frontal may look little bulgy, but it is benign. It just goes away in few days' time. So I don't think that that's the reason why you should discourage vitamin A. We must encourage to everyone to take vitamin A. Coming to vitamin A in measles, the Cochrane review is very strong to say that there is 18% survival benefit, and also there is benefit to the decreasing the mobility, that is the severity of measles. So I think there is no reason why we should shy away from giving the dose as recommended by public.
Sir, can you give extra doses of vitamin A after 4 to 6 weeks in confirmed case of measles?
So when we were students, we were told to give 3 doses, day 1, day 2, and then day at a time of discharge. But now we don't do that. Just day 1, day 2 is enough.
Sir, Yewle sir, can you throw more light regarding what is exactly outbreak, so that as a practicing pediatrician, I should know that
more than 5 cases which are flagged of fever with rash, or more than 2 confirmed cases, is defined as an outbreak.
okay. So how
So
can
I think
is a population which is catered to by a health post.
So I just, I mean, Dr. Katkar is there, but in a given health post, if you have 5 cases of fever with rash, that is a suspected outbreak. Then those 5 cases, within 7 days, they are reported, then a swab is taken from the throat for measles PCR. If they are above 7 days, then the antibody level is taken. And when 2 of these 5 become positive for measles, that's measles outbreak. If 2 of them are positive for rubella, it's a rubella outbreak. If 2 of them are positive for both measles and rubella, it's a MR outbreak. There has been no rubella or MR outbreak so far. Luckily, all have been measles outbreak. In fact, there are 110 measles outbreak in Maharashtra, and 55 of them are in Mumbai. So this is the definition that is used. And if I am not mistaken, because these laboratories are so overworked now with the cases, that if there is an outbreak, like say Govandi has an outbreak, then if you now have another 10 cases reported of fever with rash, they will not be tested, because it's not possible to waste your resources in those areas where there's already an outbreak. Just treat them as measles, give them vitamin A, and do the case management as it is defined, and reserve this testing for new areas, so that you detect new areas and know the spread of the virus, so that you can do outbreak response immunization in those new areas. And in fact, you'll be surprised that after the Govandi, Entofil, and Dharavi, there have been now 16 out of 24 municipal wards in Mumbai have outbreaks. So that includes Kandivali, Borivali, even South Bombay, things like that. So we should use the resource, because doing so many PCR is not easy. Doing so many antibodies is not easy. But at the same time, if you have a severe measles-like illness admitted in your hospital, and you reported and you have collected the blood for antibody, then of course they will do the antibody for that patient.
And sir, this 5 cases criteria is within last 4 weeks. So many
Yes.
will report those, and they are coming as outbreak areas. So
Correct.
that is one reason why
Correct.
more outbreak areas are defined. And there is strict criteria to tell outbreak free zone also after that. That is
Yeah,
up
so
to
they are-
6 weeks, no case reported.
Yeah.
So that continues as a counting.
So I think 2 or 4 of the outbreaks have been closed, which means they have now no
Yeah.
more cases from those areas.
Yeah, if we don't get a case for 4 weeks after the last case, then we close that outbreak. Fever rash case.
Fever
And
rash,
yeah, and there are basically, when we flag the outbreak, that is a flag outbreak first, and then we confirm the outbreak. So there are
Right.
basically there are 2 types. When we say outbreak, it can be a flagged outbreak or it can be a confirmed outbreak.
Yeah.
So when we get 5 cases in 4 consecutive weeks in one health post area, then we declare that as, we flag that as outbreak. Okay. And then we collect 5 serum samples and 2 throat swabs from that 5 patients, and we send to the Hafkin lab. As Dr. Shah sir has said, if the case is reported within 7 days after onset of rash, then we collect 1 throat swab and 1 serum sample. And if the case is reported from 8 to 28 days after onset of rash, then we collect only 1 serum sample. And the serum sample tested for IgM. And as Dr. Shah sir has said, if we get 2 positive cases out of 5 cases for measles, then that is a confirmed measles outbreak. And if you get 2 positive cases of rubella, then that is a rubella confirmed outbreak. And if you get 2 positive for measles, 2 positive for rubella, that is a mixed outbreak. measles plus rubella outbreak. And if you get a single case, positive case of measles or single case positive for rubella, then that is a confirmed case, but the outbreak is still, it is negative. So that is how we classify each and every outbreak.
And in fact,
and
there was, sorry, sir, go ahead.
Yes, and just to add that when we get additional cases from that particular outbreak area, then just we keep on adding those cases in our line list. And if that that outbreak it gets confirmed, then all these added cases, which are additional cases, are AP-linked cases. These cases are AP-linked to this outbreak. So they are counted as a measles cases only. Yeah. Yes,
So there was also in with the previous two discussion, one by the Maharashtra IAP and one with IAP, there was a fervent appeal that the reports of the antibody and the PCR test should be shared with the primary pediatrician who has reported the case, so that he also is in the loop to understand what happened. So I think probably in past, because of such a workload, it was not easy for everyone to get back the report in time. But I'm sure Dr. Katkar was there in the Maharashtra IAP also, and Dr. Shimpi was there, and they had promised that they will see to it that the local health officers actually share this report with the primary pediatrician, so that you know what happened to your case.
So, the question to Katkar, sir, I am practicing in Yewle. So, how I will understand that I am this area is outbreak, or is there any emergency helpline? I will compliment to Katkar, sir, that he is one of the most, I will say, most available WHO official to me. He will respond within seconds. So you are my emergency helpline. But for those who don't know this emergency helpline, so is there any facility that in the emergency helpline, or and how you actually inform the local pediatricians in that area? Question to Katkar, sir.
yes, sir.
Dr. Katkar's number is emergency helpline.
Ideally, sir, when you get a fever rash case, you report. Ideally, it should be reported to the medical officer of that particular area. Like there is a PHC, then you can report that case to the medical officer, or to the RCHO, like Dr. Shinde sir is there, or to me. Okay, say yeah. And whatever activities they do, I mean, they investigate the case, they collect the sample, they send to the lab, and that and the results, or when they get the results, actually that should be informed to the pediatrician, as I mean to the doctor who has notified that case. But it becomes very difficult, because because what is happening is when the samples are sent to a lab sends the reports to Delhi, then Delhi they send the reports to my office. Okay, and from my office, then I send all the reports to the Dr. Shinde sir's office, that is DHO's office, right? Because we get a lot of cases, and out of that, most of the cases are negative. But we get negative also, we have to report, we have to inform them, and again positive cases. So we inform to the district health authorities, and then they are supposed to percolate that passage to the medical officer, and then medical officer can give the information to the pediatrician or the doctor who has notified that case. So this is how actually the this thing is. But I mean, now Dr. Shah sir has said that now, because everything is fast tracked. Even we previously we used to get cases. It used to take at least 8 to 10 days to get the report. But now we are getting reports, sir, within 2 to 3 days.
Yeah, exactly.
Yes, sir.
So Dhananjay, also is important as to how a doctor reports. Many of the doctors don't know where to report. So what we did after the last Mumbai IP CME, we caught hold of the SMO from Bombay, Dr. Meeta, and she has shared a list of the health officers of all wards of Mumbai, and that their number, email ID, contact list, besides all the 3 SMOs from Mumbai area. So that list is shared with all IP Mumbai pediatricians. And then now any member knows from his say L ward. So who is the L ward officer? He will refer either on WhatsApp, phone, SMS, or email, or whatever. So that's all these ways of communication are okay when you want to report. But idea is to report.
Oh, thank you so much, sir.
So you can do the same for Raigad. I'm sure Raigad must be catering. I don't know how many health officers are there, like municipal board or whatever. So get those important number and circulate to your members.
That can be shared on WhatsApp group also.
I must tell you that there has been such an excellent coordination between the WHO and the Navi Mumbai Municipal Corporation, Dr. Katkar and Dr. Ratnaprabha, and all the medical officers and the private IAP members are constantly bombarded. I remember the polio surveillance, the MR campaign, the whatever public-private partnership programs were taken up by corporation and WHO. They were a big success because of this excellent coordination and feedback, and contact numbers were made available. The list is displayed. The list is sent to all the pediatricians. They have really done a wonderful job.
So thank you, sir. Now I request Dhananjay Rajput to take over from here.
Thank you, Vikas sir. I just want to ask one question regarding vaccination. Should we prepone the vaccination for the 15 months and 5 years MMR dose?
Correct.
So if the child, yes.
So technically, all the Western countries give the first MMR from 12 months of age onwards, and US gives second MMR at 5 years because there the school entry is at 5 years, and that's a captive population. And to get school admission, they have to necessarily submit the vaccine record and to have completed the vaccination. So it's like a captive population, which is easy to give the second dose. Many European countries give the second MMR 3 months after the first dose at 18 months. So they give 15 months, 12 to 15 months MMR1, varicella-1, and at 15 to 18 months MMR2 and varicella-2. So you can do this way. So now when we say that we should give MMR at 15 months, suppose the child is 14 months and he's worried about MMR outbreak, instead of giving him an extra dose, I would prepone his 15 months MMR till even if you get it 12 months and 3 months after the 9 months dose, it is a scientifically valid dose. Same for 5 years. Child comes at 3 years, 4 years, and he wants to take this last dose of MMR early because of worry. Give it. There's no harm.
And one more thing, our coverage for the third dose of MMR is very low. And we must utilize this. The people are so receptive now. Catch hold of all patients coming to a clinic and give them the third dose of MMR.
So no need to give again at the 5 years of age.
No, so if you are given the third dose 3 months after the second dose, that's a valid dose. But I only have one catch here, as we saw in USA, even when they give MMR first dose at 12 months and second at 5 years, when these children become adolescent, if there's an outbreak in that area, many of them develop mumps. So the mumps antibody wanes the fastest among all the 3 antigens. So later you give these last MMR, better it is the coverage from the point of view of there's an outbreak. And mind you, there have been mumps outbreak even in India, left, right, and center, especially in Kerala and so many other states. So during outbreak, yes, you can prepone MMR third dose also to earlier age, but in a routine work where there's no outbreak, I would still give this last MMR at 5 years or beyond because I want him to be protected till 15 months or 15 years.
Okay.
Mind you, I must tell you here, and I don't mind sharing, I developed mumps at the age of 45. My first day of joining Hinduja, and I had mumps. So I had to postpone my joining by 1 week. Fortunately, I had finished my parenting, but otherwise it could be havoc.
I'm not.
Last year I had mumps during COVID times. I had
oh my.
I'm not. Nitin, I did not talk about preponing the third dose. I'm saying that whether 4 years, 5 years, or 12 years, if the child has not received the third MMR, this is the best opportunity.
Correct. But at the same breath, would you give an extra MMR to everyone who has taken the age-appropriate MMR? The answer is no. Don't get panic. Don't create panic in the community and try to give doses which are not required as of today. Tomorrow, it may so happen that the whole situation goes out of hand so much, or because we want to eliminate measles by 2023 December, and IAP is part of the signatories to this recommendation by the NTAGI and by the government of India. So it may so happen that one more round of MR may happen, and that time we may participate. That's a different thing. But I think because there are measles outbreak in someone who has taken age-appropriate MR or MMR vaccination, there is no need to push an extra dose unless that child is from an area where there is a confirmed measles outbreak.
Okay. Thank you, sir. My question to Dr. Vijay Yewle, sir. Suppose if my housemaid comes from outbreak ward, should I allow her to come to my house or not?
Of course, you should allow. First of all, ensure that all the children in your house are vaccinated. Number one. Number two, the measles virus does not survive very long in the environment. though it is highly contagious in close density, high density population, maid coming from her house to your is very, very unlikely to carry the virus and give it to you.
Worry more about candida, TB, and other infectious diseases from your maid rather than worry about measles bringing from a community to your house.
Thank you, sir. Many parents are asking, should we send our children to nursery or daycare centers? So what should be our advice to them?
Absolutely. If they are age appropriate, vaccinated with the MR or MMR vaccine, there is no fear to curtail any of the activity of the child or of the family.
And the infants below 6 months of age, should we avoid them to go to the crowded places, or what will be the advice to them?
I don't think so, because it is extremely rare to see measles below the age of 6. And fortunately, in our country, most of the mothers, they have either naturally acquired antibodies or vaccine-induced antibodies, which are passed on, and they adequately protect the children at least for first 5 to 6 months.
So I will just add here a simile between. So why do we not give measles before 9 months? Is because of the transplacental maternal antibody. A robust mother, a nutritionally well-built mother would have enough antibodies transmitted to last for 9 to 12 months. That's why the Western countries don't even give measles-containing vaccine before 12 months, because their mothers, of course, are very robust and very nutritious and nutritionally complete. Now, if you look at the HIV, the mother who is HIV positive, the baby can have transplacental maternal antibody testing as HIV positive on ELISA kit till 18 months. Right, but in our country, when HIV was at peak in the ANCs, many of the babies became negative by 9 months. And that's because the mothers were malnourished, so they didn't have enough antibodies to be passed on to the baby, and the baby became negative by 9 to 12 months. So if you have a compromised nutritional mother, the antibodies may decay much before 9 months. That's the reason why the child may develop measles between 6 to 9 months. But before 6 months, it is too far-fetched to think that the mother will not have antibody. So don't have to have panic and give. People have tried using high-dose measles antigen vaccine for smaller children to overcome this transplacental maternal antibody, but there was such severe side effects in some of them that actually it was then taken away. So I think the bottom line is below 6 months, nothing to be done. Just wait and watch. If the child is a feverish rash, give him vitamin A 2 doses, and that's it. Between 6 to 9 months, in an area where there are lots of cases below 9 months, 10% or more, they will be given that 0 dose. And above 9 months, if your child is in outbreak area, then they'll be given that extra dose. And if you are neither of these conditions, just sit and relax and give the age-appropriate routine immunization.
Oh, thank you, sir. Next question is to Dr. Nitin Shah, sir. If the child is confirmed case of measles, then what should be the MMR schedule for him or her after?
Correct. So once you develop wild measles, it leads to lifelong immunity. So the child doesn't need any more measles immunization technically, but because there is also mumps and rubella, and standalone measles is not available, standalone mumps and rubella is not available easily in our country. Like MR vaccine used to be there in past, but is no more there. So you have to give MMR. Giving MMR in a child with recovered from measles, there is no harm. But because measles itself is an immune compromising condition, as you know, it leads to severe immunosuppression. So you should wait for at least 4 to 6 weeks after complete recovery before you start any vaccination, including the MMR that is pending.
Okay. Thank you, sir. Thank you. Now I would request Dr. Pramod Wankhede, sir, to ask few questions.
Yes, I have already asked a few questions from my list, and sir also has answered it well. Sir, my question is that what is the isolation protocols in case of measles?
So this question was discussed even past, that do you need to admit every child with measles, or can you do home care? So if a child has no red flag sign, what are the red flag signs? Of course, severely malnourished children should be admitted because they can turn very bad very fast. If they are not malnourished, but if the fever is persisting beyond 4 days after the onset of rash, in most measles cases, within 4 days of onset of rash, the fever crashes. If it doesn't happen, that means there is some secondary complication. Third, if there is an obvious complication like severe diarrhea, dehydration, failure to take anything, oral thrush, severe conjunctivitis or a keratomalacia, or a patient having rapid breathing suggesting some pneumonia, this means this child is now complicated. or a child who is drowsy, which may be encephalopathy or electrolyte disturbance because of vomiting. These all children must be admitted in time. Otherwise, most of the other children who are otherwise okay, able to drink well, are the fever is dissipated after 3 to 4 days of rash, etc., can be kept at home, but they must be isolated from other children because they may transmit it to the other children. As Dr. Vijay said, the RO is very high, the secondary attack rate is almost 90%, which means a child who is in contact with the index case, if the child has not taken vaccine himself, he is very likely to get measles from it. So you should home isolate them away like how you used to do for COVID. For at least 4 to 5 days after the rash has disappeared. So once that has happened, I mean 4 days before the rash and 4 days after the rash, the child is infective. After that, he is not infective. Then he can be gradually mingling with the other children. And of course, explain them the danger signs as to when to report back in case the child is not admitted and is kept at home.
Okay, thank you, sir.
And vitamin A to everyone, whether mild, moderate, or severe.
Sir, should infant on formula milk receive early MMR vaccines? If the child is on formula milk?
Vijay?
No. Why should he receive? It is not through the breast milk that the antibodies cross over. They cross over transplacentally. And formula fed infants are not malnourished children. And I mean, there is no separate recommendation for formula fed. No.
Okay, sir. Thank you, sir. Thank you. Whether we should give antibiotics aggressively to PM children with measles?
So a child with PEM and who has got high fever, I would cover him with an antibiotic. Because this is not the routine case where antibiotics are not given in a febrile child. A malnourished child, definitely I would cover with antibiotic. Or a child who has got obvious signs of rapid breathing or ear discharge, or is not able to drink well, is hospitalized, etc., X-ray showing a patch, I would cover such. Or there is an evidence like high CRP, high procalcitonin, or something is grown in the blood culture. These are the indication of giving antibiotics in a child with measles. But someone who is at home, otherwise, and is doing well, there is no need to give antibiotics.
Sir, is there any change in morphology of rash in this outbreak, or the same is?
I don't think so. There is any change in morphology. Whatever cases that I saw, they were not very difficult to diagnose clinically.
And is there any change on impact of SSP after COVID, particularly in case of measles?
There has been a Vijay, go ahead. Yeah, so there has been increased number of cases of SSP seen by most of the neurologists in the country, including from Wadia Hospital, where the cases have almost doubled or tripled during these COVID years as compared to pre-COVID and now. Now, why would that happen? Now, it's not that because the measles vaccination did not happen, because as you know, SSP takes few years, 5 to 7 years after measles to develop into a slow viral disease. So if someone has not taken measles vaccine and developed measles, say in COVID in 2020, cannot have SSP in 2021 or 2022. So something is happening beyond that. So what is one conjecture is that COVID acted as an immunosuppressant. And we know long COVID is a disease which is known even in children, definitely adult, where there are a lot of chronic conditions because of a subtle immunodeficiency like picture created by COVID. So that is the conjecture not proven by any studies, but this is what the feeling is of Dr. Udani or Dr. Anaita or someone else who is reported these increased cases, that maybe COVID acted as a immunosuppressant, and that allowed the slow virus to become faster or unearth faster in children who had measles even before COVID.
Sir, my another question to Dr. Katkar, sir. What is the surveillance strategy for non-reported cases in outbreak areas? Or in our area where the cases are there but are not reported, what is the surveillance strategy for them?
Actually, as we all know, sir, we take all cases of fever and macular rash, right? Actually, we are getting cases from all the blocks, but there are, like in Raigad also, if you see, there are some blocks which are where we have the sparse population and very few doctors are there. So very few cases are reported from those areas. So actually, we try our level best to conduct meeting in those block areas of all the doctors to sensitize them. And Second thing is we always tell even to the health workers, those who are there in the PSCs or the RH, what we tell them is to sensitize all the doctors in that particular area, because we cannot go and meet each and everyone. So we are facing that problem in these remote areas where we are getting very few cases of this fever as reported to us. But we are trying our level best. Sir, I think what we can do is, that is what my suggestion is, that even uh, we have made a WhatsApp group in Panvel Corporation, in Navi Mumbai Corporation, and in even in Kalyan, so many corporations, and where in which we have all respected members from IAP, and they are reporting all the cases of PRS in that particular group. So it is very easy to report that case, right? Now we are getting cases in our WhatsApp this thing, but still we can have a separate group for that. So even all the doctors can report that cases in that particular group.
Absolutely. So just to add to what Dr. Katkar said, Pramod, is that the once there's an outbreak in an area, even a flagged outbreak, there is a house-to-house survey done, an active surveillance by the field staff. And in fact, you'll be surprised at the mind-boggling figure. There are more than some 60-70 lakh houses which have been surveyed for more children with fever, with rash, or their immunization status, so that you can then bring them for routine immunization during this campaign, which will start in December and January. So by that, they have got another some 4,000-5,000 cases of fever with rash, which probably were not reported by the primary doctor, or these people never went to a doctor to seek them. So there are both ways: an active participation by the IMA or IAP doctors or a treating doctor to report the cases to public health through the system that we said generated, including the WhatsApp group that Dr. Katkar has made and is proposed in every area, and two, by active surveillance from house to house surveillance.
Yes, sir. And just to add that when a case of fever and rash is reported, actually we do the search in that particular area to find out additional cases. Correct. And so we get a lot of cases. Even in one outbreak, we are getting 100 cases. 5 cases are reported. We flag the outbreak. But in addition to that, we are getting almost 100 cases in the single outbreak, which are added to that outbreak. Yes, sir.
So I had one question for Dr. Katkar. If I asked to the SMO in Mumbai that during this campaign for extending the routine immunization that will happen from 15 December for the first dose and 15 January for the second dose, you are going to rely, the field staff is going to rely either on the card of immunization to catch a child who has missed this dose MR1 or MR2, or if the card is missing, on a recall by the parents. Correct? Am I correct?
Yes, sir.
So in case the parents say that I have taken the age appropriate MR1, MR2, that will tick as taken vaccination. But I have seen a lot of communities bluff when they understand that they are going to be vaccinated. And if you say my child is taken and I don't have a card, they will say, okay, your child doesn't need you. So I was suggesting that if there is no card, then they should be presumed as not having received and they should be given the vaccine. Giving extra doses never harms, but this type of community manipulation will then be prevented. Because this is very, very common in Govandi area. I'm in science, so I get a lot of patients of Govandi. In fact, I said it in the Mumbai CME also, that I had a family with 2 children with measles. I reported they were very reluctant to share their details. But I said, I can't treat you unless you give me your mobile number, because I have to report, otherwise I will lose my license. And then they gave it. After 1 month, they came back. I asked them what happened. They say, "नहीं कुछ नहीं, we didn't have any problem." I said, "No, show me your file." I said, "नहीं, हम file नहीं लाया, भूल गया." I said, "नहीं नहीं, वो जेब में file है, निकालो." Then they brought and I had written measles report. I said, "ये तो," then they said, "साहब हम request करता है, हम इसलिए आपके पास 1 महीना नहीं आए, आप बहुत रिपोर्ट करते थे, गए टाइम वो फेशियल पाल्सी हो गया, पोलियो बोल दिया, घर में आ गया, वो बच्चा तो सीधा इधर से ट्रेन पकड़े यूपी भाग गया, अब ये 2 बच्चों को आ गया." ऐसे वो आके क्या तुमको मार दिया, कुछ तुमको कर दिया क्या, कुछ तुमको बैन कर दिया, वो तुमको हेल्प किया है, तुमको वैक्सीन देगा, तुमको दवा देगा, तुमको गाइड करेगा, उसमें क्या हर्ज है? So there is great reluctance. So the moment the community comes to know there's a way of picking the field staff for not taking vaccine because they don't want, they will say, "No, my child is taken." Then we will not achieve that 95%. That's what my suggestion is.
Yes, sir. Basically, what is happening is, like, I was also in Govandi for, 10-15 days back for that outbreak, just to assist our Dr. Mita. So, So that time also, when I used to discuss with the health workers, when we used to move in the field, especially the slum areas of Govandi, they used to tell me, each and health worker has the data of each and every family, whether the child is taken vaccine or not. So they used to tell me that there are so many children who have not taken vaccine, they have refused. So they have the record, sir. Even they say the child has received, even the parents say the child has received vaccine, but health workers are, I think most of the health workers, they are aware that child has not received the vaccine. So in spite of whatever parents are saying, we will prepare the due list of all those children who are basically the parents are refusers. So we will be
that's
vaccinating.
what that's what I told her, that either the parents show you the card or the Anganwadi worker should have a record. Both should be taken. If you see really there's a tick, then it's okay. Otherwise, you presume is not given and you should keep. So, I mean, I don't know. She didn't have the answer after that whether what's going to happen on the 15th of December.
Yes.
I agree with Dr. Nitin Shah. Most of the time, rural population, they bluff. They have taken. I don't know, Arun Katkar, we are discussing this problem so many times. I work with Asha and Anganwadi workers. And as Dr. Nitin Shah pointed out, they know who has taken, who has not taken.
Yes.
What they say. And I agree 100% Nitin Shah. There is no harm in giving this vaccine, one more dose.
Sir, should we report all the cases of fever with rash, even if we are suspecting dengue-like rash?
Yes.
You are
Previous
supposed
definition was fever with rash with triple C, that is cough, coryza, and conjunctivitis. But just to heighten your reporting, because you should not miss even a single case of measles, even at the expense of reporting in fact, the government is encouraging you to report all fever rash and to have non-measles fever rash rate of more than 2 per lakh. If that is not achieved, that means you are not reporting enough number of children. So irrespective of what the diagnosis is, you have to report the child with fever with rash, and they will do the appropriate investigation. As I said, once it's from an outbreak area, they are not going to collect the swab and the antibody, because it will be only to add that case as measles or otherwise. But for new areas, it will help to pick up a new area with an outbreak. So I think let's not discriminate and just report every child with fever with maculopapular rash. So articular rash, petechial rash, vesicular rash, these are all out. These are not to be reported. Only fever with maculopapular rash.
So all the questions are explained, answered are explained well. I think it is well convinced with other members also. I request Dr. Vikas to take over the charge. Are there any questions in chat box? Please take. Hello, Vikas. Dhananjay?
Yes, sir. Yes.
Do you find any questions in chat box? Please take.
One question from chat box. A non-vaccinated baby from outbreak area with rash, persistent high fever on day 5 or day 6. He's clinically stable and well hydrated. Is there any indication for hospitalization?
I already said no. If the child has no red flag signs, then you can home isolate. With explaining the red flag sign to bring back to you, if any of like severe vomiting, high fever, rapid breathing, drowsiness, oliguria, etc., will develop, that to bring back to you. And a malnourished child is better to admit in a healthcare facility, because most of the mortality is seen in children with malnutrition who have measles. So we can really help to help them to survive if they are under close observation, at least for the first 3-4 days.
But typically,
and now there are enough hospitals. At least in Mumbai, there are so many hospitals which have reserved bed for these children with fever with rash. So really don't have to travel to Kasturba all the time. There are hospitals all over the city which have created beds for this set of children.
And typically, an uncomplicated measles, as the rash appears, the fever disappears.
Correct.
Persistent rash would indicate either underlying complication or the diagnosis is something other than measles.
Okay, sir.
There is an interesting question in the chat box which says that if you have high fever and conjunctivitis and just the Koplik spots, but there is no rash still, should you report? So one of my colleagues from Atofil area, he was the first to report these measles cases from those area. He reported this case. It was taken, and lo and behold, the next day the child developed florid rash. And so it's a matter of time. I mean, you can report it and let the public decide when to investigate.
So just to add on that, because if you see the definition of the suspected case, it is basically any person with fever and macular rash, or there is or also any person in whom clinician or health worker suspects measles or rubella infection.
Correct.
So if there's a complex spot, you can
Correct.
report that case. Yes.
Absolutely.
Yes.
We are done, sir, with all the questions.
No, there are questions in chat box.
Most of them are taken, I think.
Yes, sir.
Okay. Because is there or not? No problem. Yes, forum is open to all. Those who want to ask questions, they can ask that.
So people on Zoom can unmute now. Let everyone unmute and they can ask question. So Rajendra wants to ask a question. Last question is posted.
Unmute, please. Unmute, please. Rajendra, unmute, please.
Chandurkar, साहेब कुठे आहे? हा, गिटार वाजवा की एक वेळ.
Unmute yourself. Hello.
Rajendra, unmute.
Rajendra, you are muted. Please unmute.
Chandurkar साहेब, unmute करा. No, I think he's not understanding.
Our voice is not reaching to him.
No one can call him.
Hello, Rajendra. I will call.
Yes, sir. Good evening, sir.
Nitin
Shah, sir. Yewle, sir. Sir, my question was, previously we used to give MMR at 9 months, 15 months, and 4 to 6, in any time between 4 to 6 years. Now we are giving 2 doses at 9 months and at 15 months. And third dose in the recent schedule, I can't see. So,
no. Public health, it is 2 doses, 9 months and 16 months.
Okay.
Our practice is still 9 months, 15 months, and 5 years.
Perhaps,
And we are using MMR. Public health uses MR.
Okay.
And the latest immunization guidebook is going to be inaugurated or sort of dedicated next Sunday. After that, it will be available to everyone. We will see that guide. I'm sure nothing has changed there.
Okay.
Any other questions? Dhananjay?
No, sir.
Wankhede sir. The ADS to Shinde, त्यांना काय सांगा म्हणजे like there was a meeting at collector office.
Okay. Yes, Dr. Shinde sir. Yes, please. Any message from you? Hello.
Unmute करा सांगा त्यांना.
Sir, unmute करा तुम्ही. Unmute करा. शिंदे सर, unmute करा.
कलेक्टर सरांनी एक मीटिंग घेतलेली आणि किरण पाटील सरांनी पण आता एक मीटिंग ठेवले परत.
सर तुम्ही अनम्यूट करा. शिंदे सर. डॉक्टर शिंदे प्लीज अनम्यूट.
त्यांना फोन करून सांगा, त्यांना मेसेज पोहोचत नाही.
सर जस्ट एक ऍड करायचं होतं की आपल्या रायगडमध्ये पण we have 2 confirmed outbreaks. One in Khalapur block, that is Khalapur PHC, and one in Panvel block. So in Khalapur block, there is one village, Hal. Dr. Wankhede sir कधी माहित असेल. Hal सर गाव आहे बघा, Hal आपलं minority population basically village. And 6 Dr. Suvigar has reported 2 cases from one family. And then we did additional search in that particular area and we found 6 cases of fever and rash. We took samples of all 6 cases. Actually, generally we take 5, but they took samples of 6 cases. All are unvaccinated and all are positive for measles.
Same story.
Same story, sir.
Even also.
Yes, sir. They are refusals. Yeah.
In Hal only, and
yes.
they are not for polio.
Yes, they are refusals. And even total now, Raigad has 14 confirmed cases. Out of that, 11 are unvaccinated.
And the remaining 3 have taken 2 doses, only just 1 dose.
1 has taken 1 dose, and 2 have taken 2 doses. So similar picture, what we are similar picture.
Hello, Gupta. You have any question? Hello, unmute kara. I think the host is to allow everyone to unmute.
I have just phoned him that unmute all. Actually, he has muted all.
अनम्यूट
एक
करायला
2
लावा.
मिनिटात अनम्यूट करेल सर.
It was a wonderful session. So I think all doubts have been cleared and all questions have been answered. And there is absolutely no need to panic, but act wisely.
Thanks. आता शिंदे साहेब परत कुठे गेले?
Sir, good evening. Good evening, sir. Can you hear me?
Yes.
Sir, first of all, I would like to thank all for this wonderful CME. I would like to thank organizing committee also. I want to add one point, sir. In fact, I have one submission for you, those who are in Raigad, because just now notification, I think government of Maharashtra is going to add measles in a list of notifiable diseases. This notification may came within a week or so. So I request of you all to report a fever with rash cases to nearest PSC or subcenter. Tomorrow itself, I will going to share list of THO and medical officer to IMA so that you can report cases to them. And second thing is that, sir, as a practitioner or pediatrician, when you came to such a children who is unvaccinated but due for vaccination, that is less than 5-year children who had not received any vaccine, please vaccinate or refer to nearest health facility so that we can vaccinate them. And thirdly, sir, one activity we are presently doing, it is on the way. We are preparing list of unvaccinated children's village wise, and Asha and Anganwadi workers, they are doing this, and the list may be ready by tomorrow or day after tomorrow. And after that, 15th to 25th of December, we are going to give first dose of MR vaccine those who are unvaccinated, that is left out or dropped out. And after 1 month, that is 15th to 25th of January, second dose will be given. We have enough stock of MR vaccine in Raigad. We have enough stock of vitamin A in Raigad. Thank you once again.
Shinde sir, the vitamin A which was previously provided by a liquid bottle, is it the same or some?
Yes. Same. 100 ml liquid is there, which content 1 ml content 1 lakh international unit.
Can we get it at or in our private practice?
Sir, whether it is available in open market, I don't know, but we are available at all Anganwadi center, PSC, subcenter, and all government hospitals.
सर जसं मुंबईला जसं मी सांगितलं मुंबईला आम्ही रिक्वेस्ट केल्यावर आम्हाला पब्लिक हेल्थ तर्फे त्या बॉटल्स फ्री मिळाले. They have given one bottle per pediatric because we are not going to have too many cases. म्हणजे आता जसे मी 2-3 केसेस रिफर केले अगोदर, डॉक्टर चौधरी आमचे एंडोफिल आहे त्यांनी तर चिकार केसेस एंडोफिल वरना केले, तर आम्हाला बॉटल देऊन ठेवले की पेशंट आर रेल्युक्टंट टू गो टू पब्लिक हेल्थ, ते नायदर विल टेक हिअर नॉट टेक देअर, तर ते आले की तुम्ही देऊन टाका. So the only question is that there is a spoon along with that. The spoon has a inner mark of 2.5 ml, outer mark of 5 ml. It's very difficult to do that. So what I do is I use a syringe. Exact dose will go up, because smaller than 6 months you have to give 50,000. So it will become even lesser than so that is where so use syringe. We can intelligently use syringe to calculate exact dose.
Right.
So now actually these vitamin A bottles we are getting droppers with that.
नाही ना सर, आजच मला भेटली पब्लिक हेल्थ आणि ते परत स्पूनच दिली.
अच्छा, स्पून वाले आले.
मग मी तिने सांगितलं की वाय डोंट यू यूज सिरिंज, इट इज सो इझी टू यूज सिरिंज. एक सिरिंज रोज उघडायची, 5 पेशंट आहे, किती असतात एका वेळी, तर सो
हो. मी म्हणतो डॉक्टर शिंदे सर, तुम्हाला माहिती असेल की आता जे बॉटल्स येतात, मे बी आता स्पूनचे पण येतात जसं सर म्हणतात, पण आता जे बॉटल्स येतात ना, तर त्याला जी कॅप आहे त्याचं ड्रॉपर आहे, तर त्यामुळे ड्रॉपर मध्ये ते 1 ml किंवा 2 ml त्यात मार्किंग आहेत, तर त्याप्रमाणे ते देत आहेत. पण मे बी सर स्पून वाले पण आहेत.
पण पहिलं सॉफ्ट च्यूज असायचे, ते ड्रॉप 6 ड्रॉप निघायची त्याच्यातला. So 6 drop was 1 lakh. So you give 3 drop for 50,000, 6 for 1 lakh, and give 2 such for 2 lakh. असं काहीतरी होतं. I don't know whether those soft chews gel like they are available still.
त्याची काही कल्पना नाही सर.
Correct.
कधी कधी सर कॅप्सूल्स पण येतात सर, कधी कधी कॅप्सूल्स पण सप्लाय होतात.
So they are soft chews. They are capsule.
अच्छा. Yes.
You just snip it and then the drops come out.
Yes. ते आहेत, कधी कधी असतात सर त्या.
Correct.
डॉक्टर शिंदे सर सांगू शकतील.
आहेत ओपन मार्केटमध्ये आहेत सर ते.
हा करेक्ट. डॉक्टर सुगवेकरांना काय ते सांगायचे, त्यांना अनम्यूट करा कोणतरी.
अनम्यूट करा डॉक्टर सुगवेकरांना.
सर मला पण बोलायचं.
कोण आहे? राजेंद्र?
नाही मी बोललो सर.
हा तर तुम्ही
सर मला एक प्रश्न विचारायचा आहे सर. सो इम्पॉर्टंट विटामिन why it is not available freely in open market? I mean we as IAP should request government to make it available in open market also.
नाही तर ॲबॉट कडनं व्हायटामिन ए कॅप्सूल आहे 50,000चे. may not be easy to get it, and I think some doctors said there are drops available which also have 1 ml 50 drops. So there are 2 preparations probably available already.
Okay, but sir, capsule is difficult to give to children.
No, so
I mean, if the drops or syrup is available.
No, so they are tablets. They are tablets. They are not.
Okay.
Tablet. You can crush it. But I have not used it. Frankly, I got told to the public health officer and through SMO, and I said, "Baba, एक bottle दे के रखो." तो तुरंत दे दिया. ऐसा कुछ प्रॉब्लम
नहीं. वो सर तो मांगेंगे हम अगर इधर जाएंगे तो शिंदे सर हमको देंगे, सिविल सर्जन सर देंगे, लेकिन it has to be made available freely in market.
हाँ. See, someone has put in the chat box AVT drops.
AVT drops.
धनंजय, AVT काय स्ट्रेंथ आहे जरा सांगा ना.
1 ml contains 50,000 units.
And easily available these AVT drops?
Yes,
Yes, sir, easily available.
I regularly use it. Yes.
Very good. And that's all.
Dr. Gavani pointed out. Aquasol capsules are available in market.
Aquasol soft gels are there.
Yes, soft gels.
25,000 units.
This AVT drops is from which company?
I have to confirm.
Abbott.
Yes.
Abbott said.
What happens is I've got a bottle from the Neral PHC. So the catch is we have to give it the second day 2 dose. So to the babies. So what I've done is in a plain bulb I give the second dose because they are not usually follow up. So they are reluctant also. So the first dose is given at the clinic, and the second dose you give it in the plain bulb. So
what I do is I don't charge them when I give them vitamin A. I say them I'll give free. You come tomorrow and take it. I think it makes sense what you are saying also, that just give them another dose.
Yeah.
Right.
कोणातरी बोलायचं होतं ना, कोणी अनम्यूट करा म्हणून लिहिलेलं चॅट बॉक्स मध्ये.
नाही, आज डॉक्टर सुगवेकर इज देयर.
हा तेच
सर.
उस्मानाबाद. येस प्लीज.
हा एव्हीटी ड्रॉप्स आहेत अवेलेबल आमच्याकडे पण. मी तुम्हाला ड्रॉप 1 ml कंटेन्स 50,000 4 ml चं टोटल आहे ते. साधारण 70 to 80 रुपीजच्या आसपास आहे ते. मी माझ्या फार्मसिस्टला मागवले, आता मी तुम्हाला लगेच दाखवत होते इथे. आणि एक गेले 3-4 महिन्यापासून अवेलेबल झालेले आम्हाला उस्मानाबाद मध्ये ते. आणि इट्स व्हेरी गुड. ॲक्वासल इंजेक्शन बंद झाल्यापासून प्रॉब्लेम झाला होता. त्यानंतर पुन्हा सॉफ्ट चूलचे सर त्याचा थोडा त्रास होत होता. पीत नव्हते मुलं त्यामधून काढल्यानंतर. मग ते रडायचे. त्याचे आता सॉफ्ट चूल समोर घेतले आणि समजा सिरिंजने त्यातला ऍस्पिरेट करतो आम्ही. तर मग हे एव्हीटी ड्रॉप्स आहेत ते खूप चांगले आहे. पेशंटला घरी द्यायला सांगतो, किंवा जर 2 lakhs युनिट्स आहे 1 lakh द्यायचं तरी 1 lakh मदरला द्यायला सांगतो किंवा दुसऱ्या बेबीला द्यायला सांगतो घरच्या. जे बेबी आपल्या उपयोगात आलं असं करून ते
धनंजय दाखव ना.
एव्हीटी ड्रॉप्स आहे सर ते. सम लेड केअर इंटरनॅशनल.
Yes.
Yes.
Good. I mean, the brand names are taken here only for the purpose of knowledge, and nothing to do with branding as such. It's an IAP video. Great.
एव्हीटी ड्रॉप्स आणि याचे कॉस्ट आहे 90 रुपीज आहे सर.
ओके. 4 ml.
हा 4 ml ला 2 lakh युनिट्स 2 lakh युनिट्स.
अच्छा, व्हेरी गुड.
हे इथं आहे सर 50,000 युनिट्स ला 1 ml. याच्यात
थोडं लांब ठेवा साहेब, थोडं लांब ठेवा, नाही तर ते आउट ऑफ फोकस. हा आता बरोबर दिसतं.
असं आहे.
एव्हीटी ड्रॉप्स.
ओके. दुसऱ्या कुठल्याच कंपनीचं नाहीये.
One more brand is available.
कुठला?
मला एका सिमेंट मी कोणी सांगितलं की ॲबॉटच्या टॅबलेट्स येत आहे 50,000चे.
ॲक्वासॉल म्हणून टॅबलेट येतात. ॲक्वासॉल.
हो ना, 50,000चं असतं ते.
This is a very good.
सर व्हिडिओ ऑन करा तुमचं.
Hello.
अच्छा मेडिविट
Medivit
अगेन सेम आहे 5 ml मध्ये 2 लाख आहे की एका ml मध्ये 2 लाख आहे
5 ml 2 lakhs.
5 ml 2 lakhs, so 40,000 per ml.
Yes. Medivit.
Correct.
There are many options available.
I think कुठला तरी एक चॅट मध्ये टाका हे सगळ्यांना आपण माहिती देऊ.
Okay. Yes.
You send to me, I will put it in Mumbai groups. Others can put in the other groups also.
Yes, sir.
All right.
Yes.
It will be good if you send the photograph of that, both the brand side and the content side, and send to me and Dr. Yewle. We will circulate it to all over the Mumbai and Navi Mumbai area.
Yes, sir. I will send it to you, sir.
Thank you. Thank you.
So very nice discussion. It's already 11:15, I think. So, is there any questions? Please ask. Otherwise,
सर डिनर आहे ना?
बायकोला विचारा.
Virtual dinner.
I have only one question, Dr. Wankede.
Yes, sir.
Why pediatrician only attend and arrange for such meetings? No other faculty I have seen arranging late night like this, and with such vigor, people attending public health, ekdam expert sagde barobar yeta. So I think it's a wonderful thing that IAP and pediatricians are very much agile and tuned to helping public health besides our own private practice. So I think it's a kudos to all of us and to the IAP.
Yes, sir. Thank you, sir.
Yes.
Because we finish our practice by 9:30. Yes, Dhananjay, please conclude.
Dhananjay, give the Thanksgiving.
Yes, sir. Yes. Thank you. It was the need of the hour to have discussion on this burning issue, measles outbreak and its management. So we are really fortunate to have the two stalwarts in this field, Dr. Nitin Shah sir and Dr. Vijay Yewle sir, to guide us on this IAP Raigad platform. I sincerely thank Dr. Nitin Shah sir and Dr. Vijay Yewle sir for patiently hearing and answering all the queries. Thank you very much, sir. Sincere thanks to Dr. Pramod Wankede sir, Raigad IAP president, who arranged this CME and who brought these two stalwarts on this Raigad IAP platform. Thank you, sir. Sincere thanks to Dr. Arun Katkar sir for his valuable inputs. Sincere thanks to Dr. Dabadkar sir, Dr. Gangulia sir, MAHAIP president, Dr. Jai Bhandarkar sir, the state convener, Dr. Vinayak Patil sir, vice president of MAHAIP. Sincere thanks to Dr. Jitendra Gawane sir for his inputs. Again, sincere thanks to Dr. Vikas Moore sir for his wonderful moderation. And finally, sincere thanks to Dr. Neha Singh madam and Dr. Vishal Rao sir for making this digital platform available for this forum. And finally, thanks to all the delegates who attended this session and made this virtual semi successful. Thank you one and all. Thank you very much. Good night.
Thank you.
Also, thank you to Dr. Shinde, ADHO Raigad.
Yes.
Thank you, everybody. Good night.
Thank you so much.
Sir.
Thank you. Good night.